Hi, my name's Emily. I'm a physiotherapist working at Salisbury Hospital in what's been traditionally a Parkinson's nurse role. So I work with the elderly medicine team in clinics and also with the inpatients with Parkinson's. My project looked at remodelling our outpatient Parkinson's service at Salisbury Hospital following all the disruption caused by COVID. And also I've been in post for coming up to 4 years. But when I came into the post, I was taking over from someone who had a lot of experience, who had been running clinics alongside the consultants, which was almost doubling their clinic capacity. Whereas when I came into post, I wasn't able to do that to start with. I started my clinics during COVID on the telephone and then moved into face-to-face clinics following COVID. So going into face-to-face clinics, I had a bit of a blank canvas in terms of how I wanted to run them. And actually, I was struck by the fact that some people were coming, it can take up to an hour because our catchment area is quite rural. Some people were coming in for these appointments with very well managed symptoms who only needed a short appointment and had travelled an awfully long way for that. Whereas other people had just seen their Parkinson's nurse in the community because we didn't coordinate between the acute and community services. And then there was other people who had multiple symptoms and problems and complex needs who maybe didn't have enough time in clinic. So it felt like we were using a bit of a one-size-fits-all model for patients with very different needs. Around this time also, the community Parkinson's nurse who had many years of experience left, and she'd been probably working quite considerably over her hours, which her replacement then couldn't do. And so her replacement in the community was feeling very overwhelmed. So we sat down over a cup of coffee and thought about how we could look at the services differently and coordinate a bit more. So we came up with the idea of modelling demand and capacity in both the services, in the community and the acute. So I've been looking at obviously just the acute service, and this presentation is just about what we've done in the acute. We've agreed a more coordinated approach, and the approach we've used has differentiated between the needs of the patients at different stages of their Parkinson's, instead of providing the one-size-fits-all kind of model where we just treat them all the same. And we've also differentiated between planned routine clinic follow-ups and the unplanned activity that all Parkinson's services have, where patients phone in with needs in between clinics or questions. And then obviously we phone them back, but often I think we don't record that activity. So we've looked at ways of recording, capturing that activity and planning it into our job plans as well. So in terms of the principles that we worked on, so we looked at logistics and capacity planning, and then looked at a more patient-led approach to some elements of the clinics. So starting with the logistics and capacity planning, we wanted to work to capacity so that the patients know when they will have their follow-up, with the aim of having no slippage in the clinic. So when I started, because obviously my predecessor had left, there was 3 to 4 months slippage. So the patients were coming in feeling very disgruntled about the fact that they'd been waiting for a lot longer than they were promised. And the consultant at that time wasn't really able to say why, because nobody had oversight of the clinic list. And often it was felt that central bookings had done something wrong, whereas actually the slippage was just growing because there was just not enough capacity in the clinics. So what we did was looked at the number of consultant clinic follow-up slots available in a year. So we based this on the existing clinic templates and looked at this across 41 weeks of the year, thereby allowing for annual leave, study leave and sickness and so on. We then had an idea of the number of slots we had over the year, worked out approximately how many patients we had on the caseload in each phase of the Parkinson's. So looking at the diagnosis phase, having around 20% of the caseload, 45% in the maintenance phase, 30% in the complex phase, and around 5% moving into the palliative phase. And these figures were based on previous data that we'd looked at, but they also correlated quite well with the Parkinson's UK audit data. We then worked on the general principle that the diagnosis phase patients and the complex patients would need to see a consultant on average of twice in a year, and the maintenance phase patients would be seeing the consultant annually. And this was then agreed and mirrored by how the community practitioners were going to work as well, which made it easier for them to plan in their follow-ups, because they were reading the letters and then booking their follow-ups according to when the consultant was planning to see the patient again. Obviously this may vary, but it was a good starting point. And having this data then enabled me to demonstrate to the consultants using hard data that the predictable frequency of follow-ups would allow them to see patients on time, whereas the previous system, where the default position was a 6-month follow-up, and this varied depending on how the consultant felt the patient, how much input they felt they needed, or just on gut feel, or how often the patient wanted to be seen. And this was just resulting in the perpetually increasing slippage and unhappy patients. So the second thing we did was work with the community practitioners to better align appointments. And this is shown in terms of the algorithm that we agreed between us. So this is a bit difficult to read maybe on the slide, but it's on the poster. So this is based on what I've just said about the frequency of follow-ups and who will see the patient at what point. And having this in a visual format really helped everyone in both teams to kind of see what was expected, and define the symptoms that would mean that someone was in the complex phase. Going back to the aims, so ensure that medication changes with uncertain outcomes were followed up in a timely way, and titration of medication is monitored and support available when needed. So instead of me running routine clinics alongside the consultants, I started a new telephone clinic, and this was to follow up patients who had had their medication changed in a much quicker time frame. So coming off the back of a consultant clinic, the consultant could use the outcome form to get the patient booked in to speak to me on the telephone anytime from around 2 weeks following the clinic onwards. And these would be booked automatically, which has really helped in terms of giving the consultants the confidence to stretch out their own follow-ups up to 6 months or a year, as opposed to looking at 8 weeks or 3 months, which they were sometimes doing before. So the clinics have covered all sorts of things, from changing complex regimes with anxious patients, or monitoring and titrating midodrine according to people's blood pressures for orthostatic hypertension, or helping carers to manage patients with psychosis or complex dementia symptoms, and referring them on appropriately. And the fact that I can then rebook the patients for ongoing regular follow-ups myself until the issue is stable has made my diary much easier to manage, because I'm not constantly looking at lists of patients that I'm supposed to be following up without having them booked into a formal diary system. Finally, we looked at ensuring that the patients with complex symptoms and the carers requiring more support or advice could have more frequent follow-ups than those with stable symptoms. And this really came from the confidence in the clinic capacity, meaning that consultants were able to book people in sooner, knowing that that would then be done when they asked for it to be done. So once we'd settled the plans for ensuring that the clinics were fit for purpose in terms of capacity, we started to look at how we could give the patients more of a safety net between their clinic appointments, which was important in helping to stretch out the follow-up times. It was really important that people didn't feel that they were having less follow-up appointments with no means to access the service. So we wanted to ensure that patients could contact us and receive help in a timely way, and also empower the patients to self-manage and monitor their symptoms and make use of patient-initiated follow-up, or PIFU, as required. So to do this, I set up a new phone line with an answer machine so that all the calls didn't have to go via switchboard or the secretaries. I created a safety netting document, which I've sent to the Neurology Academy so they can share this on the website. And I'm happy for anybody to use this if they think it would be helpful in their own services. This outlines what to do when certain symptoms occur. It helps the patient to distinguish between symptoms with a gradual deterioration and those with a more sudden onset, and what to do in different scenarios. For example, whether they were supposed to phone us to get their clinic appointment brought forward, or to phone the GP. And this also has contact numbers for Parkinson's UK. It has my helpline number at the hospital and the numbers for the community practitioners. I created files for the patients, which we call their personal Parkinson's file, but more or less have become known as the blue folder. And these have information from Parkinson's UK and the safety netting leaflet, and also a cover letter to the patient, explaining that we're aiming to work in partnership with them to help manage their symptoms, encouraging them to store their copies of their clinic letters in the file so that they have a patient-held record that they can then take with them if they go on holiday, or if they come into hospital, get sent to an acute hospital that's not here at Salisbury, and signposting them to Parkinson's UK and the leaflets. Another change that we made was to make sure that all the correspondence from clinic is copied to the patients, which had been a bit patchy before. But I think that's a really critical part of helping the patients to monitor their own symptoms and their medication changes, and making sure that they have the opportunity to ring and ask questions if they're unsure of anything that was said in clinic or in their letters. Finally, I worked with the Trust outpatient transformation team to set up a formal patient-initiated follow-up pathway, or a PIFU pathway, to record and monitor the calls from the patients between their routine clinic slots. So previously, any calls that the patients made to me were not recorded on Lorenzo, our electronic patient record. It was just kind of built into all the activity that I do on the inpatient wards. So it was all invisible as far as the outpatient clinics were concerned. About the same time that I started the project, the consultants received a letter from the senior management in the trust saying that we were being directed by national plans to increase the use of PIFU and reduce the planned outpatient activity. And this was in line with national targets. Working with the trust on this was important for two reasons. One was because it meant that we were on the radar of the outpatient transformation team, because our service is quite a small service compared to many of the outpatient services. It's not always very visible, and we were actually one of the first services in the trust to embrace the use of PIFU and to work creatively to help the trust meet their national targets. And actually our contribution to these targets is fairly significant. And secondly, it means that all the unplanned activity is captured electronically, and the data is visible on the outpatient dashboard that the trust use to monitor their activity. So that's going to be really valuable in the future for increasing the service capacity, if that's what needs to happen as the service grows over time with the aging population. So in terms of results, this project has been difficult to measure, but I know that both consultants are now running their clinics more or less to schedule after about 6 months of the new way of working. So we don't have any more slippage really. There have been teething problems and it has needed monitoring, but we're definitely winning at the moment. My telephone follow-up clinics have been well received by the patients and are being used more frequently. Now it's become business as usual, and the consultants know how to book patients into that. Anecdotally, the patients have really appreciated it, and it's often a good opportunity to add detail and explanations, which will then help the patients to manage their conditions better in the future. It's also been an opportunity to send more information out to patients in the post. I think it's anecdotal and it's very difficult to measure, but another benefit, I think, is that we've had less patients admitted with complications of their Parkinson's, such as falls from postural hypotension, who are managed within our service over the last few months. And obviously this is difficult to measure, but my inpatient list is definitely shorter. I can't obviously link that necessarily to the changes we've made in clinic, but it does feel like it's heading in the right direction. There's definitely less clashes between the community and acute appointments on the whole, although there's still room for this to be improved. Our patient and public involvement team did phone some patients for feedback, and all of them rated their confidence in managing their own symptoms as 7 out of 10 or above. But again, I have no baseline data to compare this to, unfortunately. So overall, I think this is a project with no set endpoint. There's still room to look at time from referral to clinic for new patients, and we haven't started to look at that yet. The community practitioners have just started a new patient clinic, which should make a big difference to the education that we're providing the patients. We've just had our first cross-speciality 2-monthly MDT on Teams with the neurologists as well as the community. And we've just started trialing the PKG as well, with a view to integrating these into the service. So there's lots of changes still ongoing, but I think formalizing the pathways has helped us to start to work as a team better, and it started to feel like we have a service as opposed to just some clinics running alongside our inpatient service. So I think these are really strong foundations that we can continue to build on.